can everyone out there mute their mic and see if that's the issue? All right, Mike, I think we're ready to get started.
All right. I had several kind of topics. Most of this is related to vaccination. And I guess just briefly, I'd go over that currently worldwide, there's been 85 million COVID cases with 1.8 million deaths. In the US, that number's about 20.8 million with 352,000 deaths. In Montana, we've seen almost 83,000 cases with 975 deaths. Locally in Missoula County, we're at 6,495 cases with 55 deaths. So if we look back, there's a lot of debate about how accurate these numbers are. And honestly, I think the numbers are about as good as we can expect. We know that the cause of death numbers are probably going to lag several weeks behind the death as those certificates get processed and then recorded. So, we're always a little bit behind on that data, but it's pretty good. The death certificate stuff, let's see if I can bring this up. So this is kind of how death certificates look. Can everyone see this? Okay, so if you look here, it says immediate cause of death, and that they put acute respiratory distress syndrome in there as the cause of death, and that means the patient died from patient on a ventilator who they were unable to to continue to support them, and they developed progressive anoxic injury and complications from hypoxemia and respiratory failure, and that is due to pneumonia as a consequence of COVID-19. So that's kind of how death certificates get filled out. And this would be for someone who passed away in the ICU from COVID on a ventilator. So the cause of death, the immediate cause is the acute respiratory distress syndrome, but it's a consequence of COVID pneumonia. So I've heard a lot of people say, well, these are people who were going to die anyways, and this is not a COVID death, because if you look at the next line, there's a part 2 there. It says significant conditions contributing to death. And this is where I would put in things like they have bad coronary syndrome, they have bad COPD, they whatever. But the thing that precipitated that death was COVID and COVID pneumonia. So we wouldn't say if a cancer patient comes to the hospital and they have a pulmonary embolus and they end up dying from a PE, we wouldn't say that the cause of death is cancer. That would be, it'd be a complicating factor where you could say that would be, they'd die from, pulmonary embolus or, cardiogenic shock as a consequence of pulmonary embolus. And then you could say that it might be due to, coagulopathy from cancer. So, it's the same kind of thing. Or, someone who has a, MI who dies of cardiogenic shock, but they, they recently had some other health condition. The cause of death is kind of the thing that acutely led to them expiring. Not necessarily progression of an underlying illness. While that may have been contributory, it was not the cause of death. So I guess I thought that it would be helpful kind of for people to see how that kind of works. You can see these modifiers down here. There's did tobacco contribute to this, and other things here. But this is kind of how those death determinations are made. So let me end this. So I think a good way to look at this is something called excess mortality. And I'm going to pull up a different one here. So this is kind of excess mortality during COVID. This is raw numbers. Excess mortality is kind of calculated by looking at the the deaths per week, so a weekly total, and looking back at the average from 2015 to 2019. So this is kind of just raw number of deaths from all causes in the United States. And you can see that those averages from 2015 to 2019 are significantly lower than they were coming into, March. So when I look at this, I think that something has dramatically changed in health in our country. And this is a tremendous number of, excess deaths. So if you look at those averages from 2015 to 2019, there's, they kind of vary seasonally actually. And that's a normal kind of pattern where we start to see, increased respiratory causes of death, like from pneumonia and influenzas during flu season. But you can see that our current pattern is well out, outside of that, normal pattern. I'm going to end this one, and I have a kind of different one here to look at this a little bit differently. So this is data from the CDC, and they look at this a little bit differently, where they put kind of an error bar in there. So you can see the average is in blue from 2015 to 2019. The orange line that they make in here is kind of the 95th percentile of the error of those estimates. So what you can expect from not only increased population from year to year, but also the error bars of that estimate. So if we look back, along this, we go through 2017, 18, 19, and into January of 2020, into January of 2020, and something pretty dramatic is happening here, where we start to see these excess mortalities. If there was a lot of variation year to year, you would expect to, see a lot of numbers outside of excess mortality error that they would calculate. And this year, we've been consistently outside of that by statistically significant margins. So this is very different. And, some of this, I would say that not all of this is COVID. I would think the other things that are in play here is that some people are not seeking care for some of their other chronic conditions. And that's led to excess mortality because, the fears associated with, being hospitalized. We've had people in Missoula refuse to be hospitalized for things that, could be potentially life-threatening because they don't want to be anywhere near patients who have COVID, or they don't want to be in the hospital. So this is kind of the public health thing that we can look at. And while those numbers about COVID deaths, you may dispute those, I think they're roughly as accurate a numbers as we can expect to get. And the excess mortality data is dramatic. I think this is something, we haven't seen in the last, 20 years, a spike in excess mortality across our country like this. So the other thing I guess I would add in too is that, I lost my train of thought here for a minute, but is basically that I've also heard some people mentioning that the hospital is getting increased reimbursement by diagnosing COVID. And that is flatly not true. Just so people are aware, the hospital is getting reimbursed a little bit less than normal because of our payer mix. So we have a lot more people who when they're getting admitted, have less coverage. And unless we have, people who have like Blue Cross or, other private insurance, if we admit higher percentage of Medicare and Medicaid patients, it doesn't cover our operating costs. So actually, our reimbursement right now is lower for a number of reasons. We're doing, less elective procedures, not so much elective, but, kind of semi-urgent things. Like if we're, not doing some of our heart valve surgeries and stuff like that, typically generate, revenue to keep the hospital running right now. So we're actually, you know, operating on a deficit to a lower margin than average. So are there questions about those issues in particular before we kind of go on to the next part of this? Nope. All right. So that total number of excess deaths right now, just in the United States, is somewhere around 300,000. So 300 and something thousand. And that was last calculated at the end of October, I think, because, you know, again, the data really lags behind the current weekly data that we're getting. And 2 out of 3 of those excess deaths in from January to October were as a consequence of COVID. And I think those numbers are as accurate as we can get. So I'll move on to the vaccination if there's no other questions about that. Okay, so again, I'm going to emphasize that I really think vaccination is the single greatest achievement of modern medicine. No other medical intervention has, you know, saved as many lives and morbidity as vaccination. And conceptually, when we look at this, it makes a lot of sense, because if we wait till someone has a condition to start treating them, we're already behind the curve, especially for, you know, viruses that replicate at, you know, logarithmic progression. So we're just, you know, way behind the curve once someone's already infected. And I think that's why you're seeing a lot of things like immunologics, the immunoglobulin infusions, are really not as beneficial as we'd hoped. In fact, just so people are aware, the ID Society of America and the NIH are currently not recommending any of the, you know, antibody infusions that were big in the media. They just really haven't panned out as being beneficial. Certainly they don't have any improvement in survival, and they don't benefit people who are hospitalized and require oxygen. Currently, the single therapy, besides good respiratory care, that has really survival benefit is dexamethasone. Remdesivir has minimal benefit. A lot of other things that were done initially really have completely passed by the wayside. Some areas are still doing those because they don't have access to other therapies. So the vaccine that we're looking at locally are Pfizer and Moderna. They're both mRNA vaccinations. We kind of went over this last time, but they're basically in a little lipid capsule that helps deliver those to our cells, because mRNA in our body is degraded so rapidly that it can't be used for a vaccine outside of this particular delivery medicine or method. Sorry, this delivery method. This delivery method does not require any live virus. There is no, you know, eggs in this, and it uses our own cells machinery to generate a portion of this spike protein that is antigenic to our body. So we create antibodies to this. And this is important for a couple of reasons. We kind of glossed over a little of this maybe last time, but the benefit of this is, first of all, that there is not a huge amount of mutation going on within the spike protein portion of the COVID vaccine, because that's how it's really requires itself to bind to the ACE receptor to get into cells. So that's a good target for our vaccine, because A is involved in, you know, the binding of the virus to cells, and B does not exhibit a lot of genetic variability. If we look at things like influenza, the vaccine is constantly rearranging every year between the H and the N domains, and the variability is really high, which leads to influenza vaccines usually having, you know, somewhere around a 40% effective rate, which probably still adds some benefit. But you know, the rest of the genome of the virus is kind of constantly changing, and so that's a good target right now. Now, what's going to happen in the future, I can't say. Like, we've already heard in the news that there's a new variant that is much more transmissible, but doesn't have any increased, you know, mortality rate with it, which is good and bad, right? I mean, if the mortality rate doesn't increase, if people get infected, that's good. But if you're infecting, you know, 70% more people, that's not great. So the the way that we're going to be successful in potentially overcoming this virus has to be through vaccination. I'll tell you, because if we wait till we're treating people who are already symptomatic, that is not going to work well. And we're already seeing the long-term immunity of people who've had the virus is not great. And so far from the data from the vaccine looks to be better from the vaccine than the virus. The other issue here is that the amount of the population it's going to take to get to a herd immunity rate naturally is probably not sustainable for our healthcare system. If we wait till we get 80% of the population, which is a conservative estimate, to have been exposed to COVID, the excess mortality and amount of hospitalizations that would be associated with that are not sustainable. So we need to get probably some experts are estimating we need to get as many as 90% of the population vaccinated to get herd immunity just from the vaccine. And that's really probably our only chance to prevent this either becoming endemic in our population, so we're yearly having to deal with this, or we end up with pretty tremendous excess mortality and excess hospitalizations. So it's really important that we look at it that way. And I've heard a lot of arguments like, well, won't we get herd immunity from the natural progression of the virus? And I would say, look at measles and polio. Did we ever get herd immunity for those things? No, the only way that we effectively treated those things was through vaccination. And it required essentially trying to locate everyone to get them vaccinated. If we look at the vaccines for polio and for measles, they have comparable effectiveness to the current COVID vaccine. So they're in the 90% effective range. So that's a comparable problem we're looking at. So I hear a lot of concerns about side effects. So I will say that there are some side effects from the vaccine, it looks like, and most of them are relatively mild. And they are not any different than any other vaccine as far as those that we've identified. We have, more than 20-some thousand people in just the Pfizer arm of the vaccine trial, which is more than we usually have for our annual influenza vaccine. And it doesn't look like we're seeing any, excess amount of adverse reactions at this point. So I think that the vaccine is, safe at this point, and I think it's as well studied as we can hope for right now. And could there be complications down the line? It's possible. But I'm going to tell you that if you look at the complications of having COVID, even if you have mild symptoms that do not require hospitalization, those are often prolonged. Whereas none of the complications that they've seen so far from the COVID vaccine have appeared to be prolonged. So I would much rather risk the complications of a vaccine that has not been associated, with deaths or, heart failure or neuropathy or multi-system inflammatory syndrome or any of these other things that are definitely bad versus things that might be possible. So I think, we have had some anaphylaxis reactions, and none of those have required hospitalization so far, just, emergency treatment versus, thousands of people on ventilators and people with significant complications after COVID. Again, I think that, your risk of being in a car accident driving to work far exceeds any risk from the vaccine. So, Providence Systems in Montana has already vaccinated 1,600 people without any significant complications. They've had some people who've had, again, some of these minor to moderate reactions, but nothing that's persistent. And, I'm due for my second vaccine on the 7th. So I think it's important that you get it even if you've had COVID, because the immunity from having COVID does not look to be as robust as from vaccination. I guess another way to think about this is ACLS. So looking at ACLS, we do things like give epinephrine in ACLS, and there's essentially no evidence of improved neurologic survival with that, but we still do it because there may be some marginal benefit. vaccinating people does not have marginal benefits. It has, tremendous benefits, and really is the only reasonable way that we're going to get, have any impact on this pandemic right now. So, I've also heard things about, well, should we be wearing masks and doing social distancing after getting the vaccine? And I think the answer is yes, for a couple of reasons. And the first is leadership. People in the community, again, look to us as leaders. And if they see us doing this stuff, they will say that, well, maybe this is important. And maybe you change one person's mind, which would be good. The other issue, I think, is that, not all the people in the community know who you are. And if you're not wearing a mask, they may just assume the opposite, that, well, masks aren't necessarily benefit that person's not wearing them. They don't know that you've been vaccinated. Also, while these trials have really shown that people develop, antibodies to it, they really haven't shown that the studies were not designed to show that people are not still infectious. And while I think it's highly unlikely that people who've been vaccinated are infectious 21 days after their second vaccine, I think that it is still very remotely possible. And again, I think the benefits of wearing a mask for public health reasons and perception is worth it in my mind. So, I'm trying to think if I had any other big points. Those were the bullets that I had here. I guess I'd open it up for people who have comments or questions.
I have a quick question. I had heard there might be a holdup on the second vaccination, the second dose of the vaccination. What happens if you don't get it in that 21 to 28 day period after your first? Will it mute the whole thing and you got to start over?
21 days for Pfizer, 28 for Moderna, and I don't have a specific answer for that other than I would not delay my first vaccination. But it does need to be the same vaccine. So if you got Pfizer in the first round, you can't switch to Moderna for the second dose. But I would say that I would not delay the first vaccination based on that. And then we'll have to see how we deal with that problem down the line. My guess is that if you get it outside of that window, it's may not be quite as good. Maybe you go from 95% effective to 85% effective, but I would not delay the first dose of the vaccine based on that.
Dr. Kremkau, one of the things that's been a little bit unclear in some of the recent publications and stuff is whether or not mRNA technology has been used prior to this in vaccinations. Is this the first time they've used an mRNA mechanism?
No, so they started, mRNA vaccination started in the 1990s as a biological research technique. And then for the last 10 years, they've had some vaccinations being used overseas with this. Zika vaccination trial was done using this modality, as well as, I can't remember if it was the Ebola, or there have been several other vaccinations that have used this delivery system. There's also been trials of cancer chemotherapeutics, like targeted immunotherapy, where basically you inject a mRNA sequence for a portion of a cancer cell into your body that you generate your own antibodies towards. So it's a biomedical technique that's been used kind of more routinely in the last 10 years, but has about 30 years of experience. So this is the first widely used vaccination strategy using this, though.
Another thing that I wanted to ask about, I see a lot in the news, and I'm just asking more for an ability for us to convey accurate information as healthcare providers when asked by the public. But one of the big things that issues that comes up in discussions is the fact that they granted essentially liability immunity to the pharmaceutical corporations for this vaccination, which they hadn't in the past. Is that, I mean, do you have any information regarding that? I know that's one of the big paranoia drivers, is people saying that they exempted them from liability lawsuits with this vaccination.
I don't know the exact details of that. I'd have to look. I'll see what I can find about that and get it to you, man. I know that I don't know if that protection is just offered to the company from the federal government, or if that is like there's some kind of blanket no lawsuit clause. I don't know the details of that, but my guess is that, like anything else, that if something does happen, you're probably, this is America and you can sue people for anything apparently. So. I will say that the vaccine does not contain aluminum or mercury. It's not made from like fetal tissue, and it has a very low microchip count.
Okay.
So I was gonna supply some information here. So the liability portion of that, as I understand, did not just solely have to do with people potentially suing because of adverse reactions of the vaccine itself. That liability also had to do with, if a pharmaceutical company spent all this money, you know, they had to go into spending a lot of money to create a vaccine that was not successful, they would not be on the hook for that loss. That's also part of the liability that the government was trying to help with, so that these pharmaceutical companies would take it upon themselves to do this kind of, you know, highly costly research to develop this vaccine. And yet at the end, if it didn't work out, they weren't out billions of dollars. So it wasn't just having to do with adverse reactions. And after we look at the research and they went through the proper steps, and you look at the amount of people involved in the study and the results of those studies, there has not been any results that have borne out any adverse reactions that would even really come up to the level of anybody suing anybody anyway. So that's kind of a non-issue when you're talking about the liability protection part of it. And like Mike was saying, it's not like some of the vaccines that have certain additives in them, or they're using, you know, portions of virus, whatever. This has none of that in there. So there's really nothing to cause an adverse reaction per se, other than your normal immunologic kind of reactions that we all have when you get the vaccine, for example, for influenza. It's just normal, your body normally reacting as it should. It's not a negative thing, actually. So I think that's the misconception a lot of people have, is that because they created this vaccine and the pharmaceutical companies are not liable for anything, that, you know, they're not worrying about what it's going to do to people. But that's not true at all. So does that kind of clarify that a little bit more?
Absolutely, thank you. The other one that I think that they debunked, but one that was kind of scary sounding, was the claims that it had caused 4 cases of Bell's palsy. Have you guys seen on that?
But the incidence of Bell's palsy that is not out of the normal incidence of Bell's palsy in the general population anyway. And all those cases resolved on their own, as far as I understand. So it did not seem like it was necessarily caused by the vaccine itself. And I haven't heard of any additional cases that would cause for concern. Is that what you understood, Mike?
Yeah, I think when they looked at that, they look at anytime you have a study that involves a ton of patients, you have to look at what the population's risk is of a specific condition. So rare things like, Bell's palsy or transverse myelitis, even more rare, those things occur in the general population. And so while those patients are in a vaccination study, is that directly attributed? Is there a biological mechanism for it? And we don't know, but it looks like, the incidence of Bell's palsy in that group was, the actual incidence in the vaccinated group was slightly lower than we'd expect from the general population. So while there were 4 cases, that's, there's probably, 5 cases in that same group of people who didn't get the vaccine. Now, they didn't see those cases for sure in the people who got the placebo, if I remember right. So, it's something to watch. But again, a non-life-threatening complication for a life-threatening illness, I think, is a risk that is acceptable. So are there probably going to be some long-term effects in rarely in patients who get this? I think there are. And I think that is a risk that, we have to take because we're looking at, treating a population right now. I would encourage people, I think there's still a lot of people who think that the numbers around the country are inflated, but I would encourage people, if you have friends in EMS or hospital systems in Southern California right now, I would encourage you to talk to them, because talking to them right now, it is really where they are doing triage team type decision, deciding who can get a ventilator. And not only that, who to take off of a ventilator to put someone else who has a better chance of recovering on a ventilator. They're legitimately making those kinds of decisions in Southern California. There are, they're using refrigerated trucks for, more improvised morgue facilities. LA County has had a tremendous mortality. And I think one thing we've probably learned from this is that when you get to these levels of surge capacity, the mortality rate is going to go up because you're less able to take care of all the patients that you're seeing, not just the ones who are the sickest. So, I think that these are real concerns. I don't think the concerns over this virus are overblown by, maybe that's occurring somewhat in the political arena, but in the public health arena and, the medical community, the people are taking this very seriously. So. I did quickly look up this stuff too. There is something that does give blanket immunity to Pfizer and Moderna if something goes wrong with their vaccines. It's under what's called the PrEP Act. And it does look like you may be able to be reimbursed from the government if you do suffer an adverse a reaction, but it looks like the bar that you have to pass to convince them that that you've had an adverse reaction is actually fairly high. It says in the last decade, they've only had 29 successful claims. So I imagine that you'd have to have a pretty strong case for an adverse reaction to get some kind of reimbursement from the federal government for this. Any other questions or conspiracy theories?
Okay, Karen has a question.
I just wanted to ask, Marcus was talking about like preventative, like COVID patients taking aspirin, and like because they're having so many coagulation problems. I just wondering if you could talk about that.
Could you hear that, Mike?
No, I can't hear that. Something about aspirin.
A little bit. Sorry.
Hey, so I was on shift with Marcus, and he was just talking about increased coagulation in COVID patients. Can you hear me?
Yes.
Okay. And he was talking about preventative aspirin for patients that have COVID. And I was just wondering if you could talk about that a little bit.
No, I think there's been discussion in the critical care and ID community about using anticoagulation in patients with COVID because of the thrombotic complications. I'm not fully aware of the mechanisms involved in those. They appear to be, blood clots, venous clotting primarily, but we did have a patient with severe COVID who developed a thrombosis of his coronary artery bypasses recently, as well as developed a thrombotic stroke in the basilar artery. So is this something that an antiplatelet drug would help? My guess is that aspirin at a low dose has health benefits regardless and probably is not harmful, but I haven't seen the specific data on that. I know there are some institutions that, based on D-dimer levels, were dosing heparin. I can try and find out the answers to that to you. I think that the people who are really at risk for that are people with severe COVID, though. So that would be, hospitalized patients with this inflammatory phase, that's occurring somewhere around 8 to 10 days of symptoms. And I think that those people may benefit from it. But I don't know the specific data for aspirin, I'm sorry. It does look like there's one study using 412 patients who got aspirin, and they found a decreased incidence of thrombotic side effects. It looks like 30 to 70% of COVID patients in the ICU will develop DVT or pulmonary embolus. Most patients in the intensive care unit on ventilator are going to get prophylactic doses of heparin or equivalent agents while they're in the ICU. And it does look like there may be some benefit from aspirin. It did suggest that, there's a risk reduction. There appears to be association with decreased chances of being put on the ventilator and less likely to be admitted to the ICU in patients taking aspirin. I think bigger studies probably need to be done, but it looks like there may be some benefit. So,
do you have any information on the new strain that's going around that's supposed to be more contagious?
So from what I understand, that strain, while it's more contagious, again, doesn't have an increased, mortality rate associated with it. It does look like that strain they don't anticipate that the vaccine should be, have any different benefit in those patients, because it looks like, again, the domain that encodes the spike protein is relatively consistent in those, and they think the vaccine should be effective for that. We have not seen it in Montana, but we are starting to test for it, so.
Anybody else have questions? Mike, do you want to, John, do you want to address the cancel forms that we have and whether we're rolling those out in more serious ways?
Dave, I can't quite understand you. I'm sorry.
Do you want to address the cancel forms at all?
Oh, yeah, I think the cancel forms, again, those are, I think we should probably be using those. Again, they're really selecting out the very low risk population. And if there's any kind of concern and they don't want to consent to non-transport, then we should transport them. I don't think it's going to significantly limit the patients we're transferring right now. Our COVID hospitalizations right now are way down. I guess I'm curious to see what's going to happen in the next 10 days after people are getting back from all their holiday vacations. We had the highest amount of air travel, in a single weekend since the pandemic started. And I don't know how that's going to impact our local situation. I think it may have bigger national impacts, unfortunately, but. I think this form is very conservative. So
we have 5,000 of them at our office here at Soulstone. So if you guys need some, come by and pick them up. Everybody.
I had not heard of reservations of using this form until today, so I don't have any specific reports of that. It would be interesting to know what those reservations are, so that we can address those and talk through it. Again, I agree with what Mike is saying, very low risk people that we're, using these forms on. And it's really, to help downstream in the EDs with the amount of patients that they're seeing. I guess I had heard something that taking patients to the ED and there's no complaint about the volume of patients, but that can change very quickly. So I don't know if I would necessarily go by what you're hearing in the EDs themselves.
So I just sent a link to the infectious disease advisor about some of the current aspirin stuff. I'll look into this and see if I can get more specific information. I suspect that taking aspirin is of some benefit, but I don't know how much. So.
Anybody else out there have questions about these forms in particular, or just procedural stuff with using them? Okay, anything else? Mike, John?
I don't have anything else. Get questions to Dave. We can try and answer all these things to our best of our ability, and try not to get tired of doing all this stuff. I will say that if we don't vaccinate enough people, we could be continuing to do the same things we're doing now for some time. So strongly encourage everyone to get vaccinated as soon as they possibly can. There are going to be limitations in the availability of vaccine for some time, I would guess. But I would prefer not to be doing this, in the spring of 2022.
Okay, thanks everybody. We'll record this and put it on our Messie's YouTube site for folks to watch. Thank you very much.
All right, thank you.